I was arguing for only 2 years. That was the max I wanted to do. And my supervisor, well, now my supervisor, he was saying, how about 5 years? And I remember just being this stubborn kid, 26 years old or 28, I don't remember, saying, no more than 2 years, that's what I'm going to do. And then 2 turned into 3, 4, 5, and now it's 15 years. I'm pretty much going to start building a home over there, literally. Thank you very much. I'm definitely more excited to give this talk here because this is where it all started for me. 2006 August is when I moved to Birmingham, Alabama from Armenia to do my MPH, after med school, to do my MPH over here. And then May, I think, is when we graduated. So this is actually like being back home. I'm going to talk about a new topic for our department over there. I'll just give you a couple of minutes about the background. So UAB in 2001 started a research center in Zambia called Center for Infectious Disease Research in Zambia, also known as CIDRZ. In 2011, after 10 years, it became a local NGO. And now CIDRZ is the biggest research institution in the country with 1,500 plus full-time staff, 45 active projects and research studies ranging from adult HIV, pediatric HIV, reproductive maternal newborn child health, enteric diseases, social sciences, TB, malaria, and others, whatever you can think of. It's the biggest research institution in the country. It's become globally renowned. It's a phenomenal place. And I'm marketing it because if any of you guys are interested in doing internships or postgraduate and research work, definitely reach out to us and to me or to whoever you know at CIDRZ. So throughout these years, we set up 2 research sites. One of them was at CIDRZ, and then the other one was at the University Teaching Hospital, which is the tertiary level hospital in the country. We had we still have an NIH-funded project with Dr. Wally Carlo from Neonatology, the Global Network for Women's and Children's Health Research. So we set up a research infrastructure over there that's been going for 15 years. And then in 2016, I decided to separate myself from that and set up my own work, which was the Department of Reproductive, Maternal, Newborn, and Child Health. Since 2016, we've had projects in the field of safe motherhood, so postpartum depression, postpartum hemorrhage, vertical transmission of STIs. Reproductive health, cervical cancer is primarily what we're looking at, either validation of diagnostic equipment, progression to regression of HPV. And the recent one that we're working on the grant application, is use of AI for early identification of precancerous lesions. Neonatal mortality, neonatal outcomes, obviously that being my niche, and then general validation of medical equipment, as long as they fall under the MCH portfolio. But today we'll talk about a different topic, but before we go to that, I want to just talk about, give you some background over here. So one thing that I like to say, we like to say when we're talking about Zambia is that Zambia is the same size as Texas. And it is. It's almost slightly smaller than Texas. But then that leads to many of my family and friends thinking that then the United States fits in Africa. Well, the reality is the United States includes my part of the world, Eastern Europe, the whole of the United States, China and India, and I think Japan as well. Yes, and Japan. So just to give you an idea of how humongous the African continent is. The globe gives you, it's like a false representation, just like the flag with my picture on it. It's false advertising. Africa, it's a remarkable continent. It's comprised of 54 countries, 1.3 billion people, 3,000 tribes, and 2,000 languages/dialects. And this is important to pay attention to, the languages and the cultural diversity. It's quite crucial to pay attention to, take into account when you're actually thinking about doing any kind of implementation work on the continent. Many people will think it's not different. Many people will say Zambia is not very different from Nigeria. West Africa is a whole different ballgame. Southern Africa is different. East Africa, so everything is different. So just small intricacies that you need to take into account when thinking about policy work or implementation or introduction of any interventions. This is one of my favorite pictures of Africa. It not only shows the huge river basin that we have on the continent, but also has the 3 famous rivers. So the Nile, as you all know, the Congo River, and then the famous Zambezi, which pours into the world famous Victoria Falls, which eventually pours into the Indian Ocean. However, while Africa is one of the richest continents, is also one of the poorest when it comes to health outcomes. And unfortunately, all of the 17 SDGs portrayed over here actually are relevant to the continent. My field, it falls within the SDG 3. So this is what we'll be talking about today. SDG 3.1, which is the maternal mortality. Goal is to reduce it to 70 per 100,000. SDG 3.2 is neonatal mortality, and the goal is to reduce it to 12 per 1,000, or when it comes to under 5, goal is to reduce it to 25 per 1,000. And the topic that we'll discuss today, SDG 3.4, mental health. So a significant number of pregnancies begin from adolescence. As you know, per WHO, adolescence is defined as between 12 to 19. So between 1 to 2 million girls below the age of 15 every year become pregnant. Girls within this age group are 5 times higher risk of dying due to complications from childbirth than any other age group. Additionally, another 21 million girls between the ages of 15 to 19 fall pregnant. And unfortunately, 50% of these 21 million are actually unintended pregnancies. And the other horrible fact about this is that almost 50% of the same 21 million pregnancies actually lead to end with unsafe abortions. 287,000 mothers die every year. If you do the math, it's actually coming to 1 mother every 2 minutes. So theoretically, by the time I'm done with my talk today, that's going to be 30 mothers that have died. The goal is to reduce maternal mortality to, as I mentioned, 70 per 100,000, which is the SDG goal for 2030. So we have only 7 years left. However, the mortality in Africa, the average mortality rate in Africa is 540 per 100,000. So it's almost 8 times higher than where we're supposed to be. It is also significantly higher than the global average, which is 210 per 100,000. And for comparison reasons, in high-income countries, maternal mortality is 13 to 17 per 100,000. So just look at this big disparity between the high-income countries and low-income countries. It's not different when it comes to neonatal outcomes as well. 2.3 million neonatal deaths comes to almost 260 deaths per day. Comes to 6,300 deaths per day. Comes to around 230 to 260 per minute. So neonatal mortality has reduced in the last decade. But unfortunately, the biggest reduction we've had has been in the under 5 mortality. So under 5 mortality has reduced significantly, but neonatal mortality has reduced at a much slower pace. And at the moment, neonatal mortality contributes to 45% of all under 5 deaths. There are many factors that fall into this, obviously, but one of them that we're still working with, and we've seen the change in many low LMICs, is number of deliveries done by skilled healthcare providers. So at the moment, globally, we're looking at around 65% or 68% deliveries being done by skilled healthcare providers. But as you can imagine, it all depends on the country and then also on the setting as well. And Zambia is no different from that. This is one of my favorite pictures. So if you look at neonatal mortality per population, as you can see that Australia almost diminishes. Russia, China, Europe is gone, America slims down, then Africa and India expand. So in terms of numbers, India has obviously more now, unfortunately, more number of mortalities. But we're going to target the African continent today, which pretty much turns into a balloon. Another one of my favorite ones is this. When we look at the number of physicians available globally, America's very similar. Australia this section becomes a spider web, but now look at Africa. It literally becomes like the stem of a balloon. And then when you look at, and to compare it with India, and this is, again, another one of those intricate things that we need to take into account when we're talking about global health. Can you guys hear me if I move away? Oh, perfect, because I hate standing in one position. So this is one of those things that we need to take into account when thinking about getting implementation work or trying to bring in proven interventions is the skilled healthcare providers. So to give you an idea, Zambia has only 1 formally trained neonatologist. Population of 19 million people. We have 1 formally trained neonatologist. We have pediatricians who can self-train on the ground because there's no other option, but we have only 1. So when we're talking about bringing an intervention to the NICU that's going to be run by neonatologists, we have to take a step back. We have to always think, what human resources do we have on the ground, and are they skilled enough to do this work? Fortunately, this has led to a lot of task shifting, policy change. So now there are a lot of things that the nurses and midwives are able to do. And it ranges from MCH to all the other departments within healthcare. But again, it's an important thing to take into account. If you do projects in India, you're going to have plenty of physicians. You're going to do projects on the African continent, you have to think about the ratio. Now, Zambia, been my home for 15 years, as I mentioned. It's a country of 19 million people. Some of us like to say it looks like a fetus. It does, like sideways, if you think about it, or if you're biased like me, obviously. We have 73 tribes, and we have 72 dialects. English is one of the national languages. Here, not very different from the other countries. The journey of a pregnancy begins, unfortunately, from adolescence as well, where in 2018, 29% of the pregnancies were among adolescent girls. Which is twice as high, just to give comparison, which is twice as high as the average in sub-Saharan Africa. Zambia is also home to 1.7 million brides, of which 400,000 of them are below the age of 15. Furthermore, 5% of the adolescent girls are actually HIV positive. 11% of women in Zambia are generally HIV positive. When we're talking about STI rates, we don't have a good number on this because we don't do routine TB, CT, NG tests of gonorrhea, chlamydia, or T. vaginalis testing. It's not part of the routine care. However, there are some small studies that have been done that where we're looking at anywhere between 2% to one of the studies was around 30%. And that was a very interesting one because they were trying to look at non-sexual transmission of T. vaginalis. So specifically looking at dorms, using sharing of towels, sharing of other hygiene products. One of the risks that we need to, just going to move this, sorry, there we go. Another important thing to note about the adolescent girls is that adolescent girls are at higher risk of delivering at home because of the stigma they face at the health facilities by the nurse midwives. And we know that deliveries at home already come with a high risk of poor delivery outcomes. But in addition to this, we also know that a lot of adolescent girls are at high risk of giving birth to preterm babies and low birth weight babies. And as you can imagine, those come with their consequences, long-term consequences as well. Maternal mortality in Zambia has reduced. We're looking at around 250 per 100,000. However, neonatal mortality actually came down to 23 per 1,000. And then in the last 2-3 years, it went up to 27 per 1,000. Many say that it's because of better recording of the outcomes, but we believe that COVID-19 actually had a huge impact on it. In 2020, when COVID first struck, Zambia, like many other countries, we did not see a difference. We didn't see a negative impact on the delivery outcomes or in healthcare services in general when it came to maternal child health. So number of antenatal care visits did not change significantly. Number of deliveries did not change. Postnatal care was also fine. I think 2021, when COVID was already spreading even more and more, I remember our now Minister of Health reported last year on the 2021 or 2021 numbers, and we saw ANC had dropped to almost 30%. Facility deliveries were almost less than half. Postnatal care was even lower. So it's very clear that COVID-19 definitely had an impact on neonatal outcomes. Unfortunately, not unfortunately, and like globally, the 3 main causes of neonatal mortality remain the same. Complications of preterm birth complications, breathing difficulties, and neonatal sepsis. This is the University Teaching Hospital. You may hear about it as Women's and Newborns Hospital, which it all falls under the same umbrella. Generally, we like to say UTH, University Teaching Hospital. So during my time, the UTH number of deliveries at UTH has dropped from around 25,000 per year to 14,000 per year, which is phenomenal because what we did is, and by saying we, sorry, I refer to it as the country. What we did is we decentralized the L&D services throughout not only the city, because Lusaka, of the 19 million people, almost 3 million are actually within Lusaka and the wider Lusaka. So we decentralized the L&D services, and that actually brought down the number of deliveries, as you can imagine. However, we did not do the same thing when it came to the NICU and KMC services, so Kangaroo Mother Care Services or the neonatal intensive care, because that requires more human resources and more capital. The NICU, number of admissions in the NICU are around 4,500 per year. We have a 60-bed capacity NICU, but at any point we have 80 babies. They sometimes go up to 120 babies. And the nurse-patient ratios you see over here are when we're looking at almost around 100 babies. Sometimes, as I said, we go up to 120, and at times we actually have 1:20 ratio. So just think about this as well now. Neonatal mortality in the NICU, before we had our first formally trained neonatologist, Dr. Kundo Mtesu, was 48%. So if your baby ends up in the UTH NICU, there's a 50-50 chance. And I want you to pay attention to this because this is going to transition to our mental health topic. Now it's come down to almost 25%. Huge reduction for us, but as you can still imagine, there's a one-to-4. And the mortality during the first 2 days, the first 48 hours, which the highest, I don't know if you've seen it into mortality charts, but day 1 is the highest, then day 2 slowly comes down, and then after 7, it's kind of like almost similar. But mortality during the first 48 hours is actually still at 25%. And this is the NICU, so we're obviously seeing the highest risk babies, not the general ones, but so we're still looking at that. And then comes the KMC. So KMC room was actually set up by us. I can say this, CIDRZ UAB. The first one was only a 10-bed capacity. And then thankfully it performed so well and the government liked the idea so much that UTH used their own funding to expand it to 26 beds KMC ward. So as you can see over here, it's very basic cubicles. You have the bed for the mother and the baby. Sometimes we have 2 mothers and 2 babies in the same room, but generally it's 1. Food is provided, all the services are provided. Again, this is all going to fit in eventually. And they now admit around 1,200 babies per year. Mortality is generally 2 babies a year. So if you think about it, it's like we're doing a great job, right? We started a study, we did a study last year, we were giving KMC babies high volume breast milk, and we were following up on them. And because it was programmatic data, we saw mortality that was higher than what we expected. Because we were thinking, you've gone to the NICU, you're stable enough, you've gone to the KMC ward, so then from KMC, you're going home, so your mortality should be lower. So when we saw the high numbers, we went to the UTH management and asked them if we could do a retrospective extraction of their KMC. For them, not for research purposes, just for them to see. And we called the mothers to babies admitted to the KMC room in 2021 because we wanted to see how many babies were alive 1 year later. 9.5% in fact. 1% was within the neonatal period, post-discharge, but still within the neonatal period, and the rest, the additional 8.5% was actually in the post-neonatal period. Now we started digging into this, and it turns out what happens is started happening often at the KMC. This is one of the reasons. But what started happening at the KMC room is the global policy is to discharge babies once they reach 1,800 to 2,000 grams. For example, UTH practices that, UAB practices that. It's not written, but it's generally we say a baby reaches 1,800 grams to 2,000 grams, you can now discharge the baby home. When we transitioned from 10 to 26 bed base, the demand was so high and we were getting more and more babies. So we would start discharging babies earlier. First it was 1,800, and then it was 1,750, then it was 1,700, then 1,650, etc., etc. Now we go as low as 1,500 grams. So as long as the baby is stable for 3 days, you're not vomiting, you're taking a food, you're putting on weight, you're not on any medications, no antibiotics, nothing. For 3 days you've been stable. We unfortunately have to discharge you because there's a baby in the NICU that needs to be discharged. Because otherwise, if the baby stays in the NICU longer, there's a chance of infection, hospital-acquired heart infection. So from here come to this, unfortunately, the baby was 1,500 gram goes. So in theory, well, we are doing a great job over here, but now we need to start working on the post-discharge, which is there are a couple of papers that have been published on the continent that talk about the poor linkage to care following the discharge from KMC. Now, with all of this in mind, going back to the 25% mortality, of your baby being admitted to the NICU, going back to the possibly almost 10% mortality, even if you've made it through the NICU, gone to the KMC, etc. So imagining all of this, imagining that a lot of the mothers are actually adolescent, a lot of them are unintended pregnancies, and all of this in mind, we decide to look at this. We decide to look at the impact of KMC word on on maternal postpartum depression. So despite all of these figures, the numbers that I just gave you, 99% of the research work in Zambia when it comes to depression or postpartum depression is exclusively linked to HIV care and treatment and adherence, which is important, but it's only that. We want to make sure that you are linked to care and you're adherent to care. So nothing else has been done. There are 2-3 papers that talk about some antenatal depression and postnatal depression, but that was it. So then we said, okay, with the SDG 3 in mind, 2030 is around the corner. Let's look at this because we work in the KMC and NICU area. So KMC should be able to do something. But so perinatal depression, to give you some background, and then we transition to the studies. So perinatal depression still remains a global public health challenge. And with less than a decade actually to reach this goal, this is even more, it's more timely and more crucial now than ever. Around 40 million newly delivered women each year are diagnosed with postpartum depression, which is almost 17% of all cases. And the global prevalence of PPD, despite all efforts, has actually gone up by 18.4%, with Africa, unfortunately, having the highest hit, up to 50%. Postpartum depression, maternal postpartum depression, is linked to maternal morbidity. It impacts the newborn in terms of non-exclusive breastfeeding, lack of follow-up for postnatal visits, malnutrition, lack of immunizations, and also the physical self-harm of the mother. So then we said, okay, so factors such as, so we said, okay, let's look at the NICU and KMC, right? So we know that mode of delivery, looking at this, we know that mode of delivery actually does impact, is impacted for postpartum depression. For example, there are studies that say that if a mother was planning on having standard vaginal delivery, but she has to go into an emergency C-section, that is actually a risk factor for postpartum depression. So we know that, and we also know from the literature that mothers whose babies are admitted to the NICU actually have a higher risk of postpartum depression as well, because your baby is physically taken away from you at birth. You probably discharge your baby for 1 minute. Your baby is physically moved from you, taken to the NICU, where your baby's life is at risk. It doesn't matter if you're in the Finland, which has the best numbers, or if you're in Zambia. The impact is the same. We also know that Kangaroo is a phenomenal low-cost computing intervention that not only reduces neonatal mortality significantly, almost 40%, depending on the weight of which you're looking at. It's been shown to work in community settings and facility settings and household settings, but we also know that it does help with maternal depression, because you're finally holding your baby, you're bonding with your baby, it's the quality of time, and it also reduces the stress levels. So we said, with that in mind, let's do an observational study. Let's look at mothers who were admitted at UTH. So cross-sectional observational study, and let's look at mothers whose babies are admitted to the neonatal intensive care unit. Mothers whose babies are admitted to the, well, mothers whose babies are admitted to the Kangaroo mother care ward, and also those that are admitted to the postnatal ward. Because we couldn't find any data in these groups, so we said let's look at all data. As you can imagine, the postnatal ward is the healthy babies, or the stable healthy babies with smooth, non-complicated deliveries. It could be C-section, it could be STD. NICU is obviously the babies that move higher level of care, unstable babies. And then you can see those that went, the way it works in Zambia. You first go to the NICU ward, and then from NICU you either go home or you go to place. There's no clear guidelines on who goes where. And we did the math based on the publications out there. We looked at the prevalence rate, and then we did the math, and we said we need 1,056, 352 in each cohort. First, our aim was to determine the incidence of PPD based on the required postnatal care. So were you in the NICU, KMC, or postnatal ward? And the second one was to determine the impact of KMC on maternal postpartum depression. So here's the flow. Kind of like jumped ahead, but here's the flow. Antenatal care, then delivery, and from delivery, you either go to postnatal ward, as I mentioned, the stable and the healthy ones, and then you go to the NICU. From postnatal, you go straight home, or you, and from the NICU, you either go to the KMC ward, and then you go to the, you go home, or you go straight home. There are no clear guidelines on what happens, who goes where. So we enrolled 1,056 mothers, and we screened them at one time point, 6 to 8 weeks postnatally, and we used the Edinburgh Postnatal Depression Scale Screening Tool, EPDS. Let's use this. So EPDS is actually a really good screening tool. It could be used antenatally around 32 to 36 weeks, and then postnatally, 6 to 8 weeks as well. It could be used among men and women as well. And one of the things I like about EPDS is it's a 10 question. Very easy to administer. Scores range between 0 to 3. And there's a total score. So there are a lot of literature that says if you score 11 and above, that means you should be flagged for possible postpartum depression. If you're 13 and above, then there's a parameters. But generally, we use the 13. For this study, we use the 13 and above. But what's also important about the EPDS score is irrespective of the score. If the mother, for example, scores 10 or 9, you have to look at questions 3, 4, and 5 because those talk about anxiety. So she could still not have postpartum depression, but she could have anxiety, and she could easily score the yes to question 3.5, which is 9 only. And you have to look at question number 10. I should have really posted that survey over here. Sorry about that. And then question number 10, which is about self-harm. So she could easily be scoring 3 or 4. But if she said yes to question number 10, what she has found is self-harm, you flag that immediately. So there are multiple things that you can learn from the EPDS actual screening. So overall postpartum depression, and then anxiety, presence of anxiety, and thoughts of self-harm. An interesting thing that I learned, and I didn't know about this, was that when it comes to men, we score, we go for lower. So anything 9 and above, there's some literature that says 7 and above, either from postpartum depression. Generally 9 is used.
Is it because of the perception of the questions and attitudes as they answer the questions?
I think women are more, mothers, I think, are ready for more. They're able to tolerate more. That's my theory. I'm not a psychologist or psychiatrist, and I say this very cautiously without offending anyone. Yeah, I think that's my theory. So here's the maternal characteristics. So overall, 61.6%, I'm just going to look at the numbers here. 61.6% of the mothers had post-secondary education. 59% of them were unemployed. 80.7% were married. And 11.2% were HIV positive. The average age of the study participants, mothers, was 25.9. Cesarean section rates were the lowest among postnatal ward, as you can imagine. And they were the highest among those admitted to the NICU. Among the infant characteristics, most babies were admitted to the hospital for more than 1 week, 38.5%, but that was primarily because, as you can see, the postnatal ward, that skewed the numbers there. Most babies stayed at the NICU for 1 week, around 68.9%. So almost 2/3 of the babies stayed in NICU for 1 week. And then the KMC ward for more than 1 week was 85.5%. Almost 94% of the babies stayed at the postnatal ward for 1 day. As you can imagine, again, it's the safe and safe deliveries with healthy outcomes. And then, to our excitement, actually, so overall postpartum depression was 20.5%. But while 20.5% of the mothers actually had PPD, mothers whose newborns were admitted to the KMC ward after NICU had a significantly lower rate of postpartum depression, 21.3%, compared to those that were directly discharged home from the NICU, 27.8%. We had a p-value of 0.01. Most women were screened positive for postpartum depression, had no source of income. Well, for 53.7% of women who were positive for PPD had no source of income, and 40% of them had a C-section. We also recorded a negative correlation between birth weight and the EPDS score. And before I go to the next step, and these findings led us to hypothesize that admission of preterm mother-infant dies to the KMC ward will actually reduce the risk of PPD. So the thought process over here was that after seeing your baby at the NICU with tubes and pipes and everything, and with that risk of obviously they don't know the 25, we don't tell anyone that there's a 25% chance that your baby's going to die. But they do see it, they do hear it from the mothers, they hear that information, the baby has died. So from here, you moved out, but you're not going straight home. Because when you go home, then you have the stigma that you had a preterm baby. You have the stigma that your baby ended up in the NICU. Why couldn't you do this? Why couldn't you do this properly? You have the stress of dealing with your partner, possibly other kids, and possibly with the in-laws as well. And most possibly, you're back into doing your household chores. So what we thought was that then sending the mothers to the KMC ward, where literally all what we were saying is you just need to stay alive. Everything is taken care of for you. Your food is taken care of. We'll tell you when to go to shower. You have the sanitary supplies, whatever you need. You just need to eat and hold your baby and bond with your baby during this 1 week. And so we said, when we saw these findings and we thought about this, then we said, okay, let's go for an RCT. And I was telling Anna this morning that I'm really excited that we put in this RCT earlier this year, and we got awarded exactly 1 week ago, last week, Wednesday. So we received, if anyone is interested in this topic, this is fine. So we got the funding from Challenges Canada to do a randomized control trial, because ours was an observational trial, right? And you guys know this, observational cohort data, observational data, huge numbers is phenomenal. You can learn an enormous amount from it. But unfortunately, when you're trying to push something into practice, you need an RCT. So we proposed to do an RCT where babies would be admitted to a NICU, up to 1,800 grams, will be randomized 1 day before discharge, not at admission. 1 day before discharge, we have physician on budget. Sorry, I don't know. So the physician would decide if the baby is stable enough to be discharged. If they are discharged, then they'll be randomized. You either go home or you go to the KMC ward. All will happen at the UK hospital again, over the 306, it's a randomized trial. And you're going to actually do this is I'm excited now. We're going to do PBS, PhD9, and ASP. Now about the rest of things now. So our first aim is to determine the effect of admission to the KMC ward on maternal postpartum depression, as you can imagine. Our second aim is to determine the effect of admission to the KMC ward on the infant's neurodevelopmental outcomes. Sorry, let me take that over here. So as part of the first aim, what we're going to do is we're going to screen mothers at 2 weeks. The EPDS score has been used as early as 2 weeks. Officially, it says you should use it during antenatal and postnatal 6 to 8 weeks. There's a lot of literature out there, and Professor Manon, who is our consultant on the study, she also said we could actually use it at 2 weeks. So this will be our baseline. And then we're going to screen at 6 to 8 weeks as it's approved. Then using the PHQ9 form, we're going to screen them at 6 months and 12 months for postpartum. So we're actually doing a prospective cohort study. Well, it's RCT, but it's prospective one. We'll use PHQ9. And then for the second one, we want to look at the impact of KMC on the infant's developmental outcomes. This is when we will use the ASQ, the ages and status questionnaire. It's easy screening tool for developmental delays. Screening, not diagnostic. The diagnostic one still remains the babies. The babies takes 45 minutes. It's quite costly, quite complicated to do. ASQ is actually parent administered as well. For our study purposes, it will be done by our healthcare providers. But simple screening tool where the babies will be screened at 6 months and 12 months. We do actually have a paper that shows that 4 of the 5 domains of ASQ match that of the babies. So we may be able to argue that this is in a way the closest to diagnosis that we have. That's easy and low cost to do. Third one is we want to do barrier analysis as well. Because we're taking the barriers of practicing KMC, because we know that since it's old, yes, it's us, but we still will ask you a question to see what barriers you have. It's a safe, controlled environment. But what happens when you go home? Do you have time to practice KMC? It's very easy to say. I have a lot of colleagues, clinicians who say, you should tell mothers to practice. I was like, okay, let's talk about this. let's talk about it. How realistic is this? Yes, I understand that by saying continuously, you can take a shower with it without playing for you. But how realistic is it to be in a low resource setting, in a low social economic place where 50% of mothers don't have income, and now suddenly I have to be sitting around and with my baby on my chest. That's just not possible. It's going to do the rest of the jobs. Unfortunately, we have to see the full picture. So we want to do barrier analysis to understand, to focus group discussions, understand what barriers are. And the other most exciting one is to determine the prevalence of paternal depression. I must admit, this is really complete. If it is, it's going on record. I probably shot myself in the foot because bringing in fathers in general, screening of depression is hard. Bringing them in a low resource setting is going to be definitely a challenge.
We do that.
Okay. How do you guys say?
It's bad.
Thank you. Yeah. So 10% are probably will get 10%. Yeah. But this is we're really excited because not only does it have not been done. I mean, the idea has not been done, and as an RCT has not been done in general. Screening fathers for postpartum depression, unless you're HIV positive, which you think that depression is HIV care, yes. But when it comes to postpartum depression, has not been done. And one of the reasons we wanted to add this is because we wanted to see if there's a correlation between this and maternal. So if one of the partners if both of them are have depressive symptoms, or if one of them has it, how does that impact? And because we're going to be screening after 12 months, will we be able to see some correlation, some linkage? And this is pretty much the plan of the study. Mothers will be screened, as I mentioned, 2 weeks and 16 weeks, EPDS, and then PhD for 6 to 12 months. Infants will be screened for ASQ at 6 to 12 months, and the fathers will be screened at 6 to 8 weeks, and then 12 months. So this was purely budgetary. We said we want to do baseline and endline to compare with a mother. And then the question, so this will take almost 24 months. So 12 months will be the enrollment. And then another 12 months, or hopefully 10 months will be the enrollment, and another 12 months to follow up and exit. I will mention one thing, so you guys don't say, oh, that's like you can use ASQ and that will be phenomenal. If you want to look at properly, you want to look at neurodevelopmental delays among newborns, ideally you want 36 months follow-up data. 6 to 12 months is definitely not going to give you a trajectory of where you're going. Having said that, what you guys are probably have heard this, or is you put in a grant idea, you get the funding, you're lucky enough, you get the funding, great, and then you start looking for other resources to extend it. So at the moment we're in discussions with another university outside of Alabama, because they're interested in neural work in Zambia. So theoretically, if they're really interested in this, then they may come in with funding and continue this follow-up on this cohort up to 36 months. Then I'll say, now we can confidently say it does have an impact enough. 6 to 12 months will give you an idea of the trajectory. So this was the first observational study in Zambia in general that looked at the impact of KMC on maternal postpartum depression. And this will be the first RCT done there as well. And as I mentioned, also the first one to involve the male partners. And Anna just gave me confidence that it's going to work out perfectly. So in conclusion, postpartum depression has a negative impact on one's productivity. But this is not negotiable at all. It impacts your mood. It impacts your social interactions, not only with your friends, but also with your child, which then eventually could lead to long-term neurodevelopmental delays or poor developmental outcomes. Depression could lead to unemployment, and this was really interesting. It could lead to unemployment, which contributes to poverty, but it could also be the reason for you to remain in poverty. So it's like a two-way thing over here. If you have postpartum depression, you could lose your job and go towards poverty. Or if you're already in poverty, if you have postpartum depression, it's going to be much harder for you to come out of it. And lastly, the children are born to mothers struggling with PPD have higher rates of morbidity, malnourishment, low uptake of vaccination, so rehospitalization quite often, and neurodevelopmental delays. So as I mentioned, if anyone will be interested in this, hopefully we're going to be starting the study sometime next year. And it's going to go on for 24 months. I think, yes, my team, Dr. Wally Carlo, obviously has been my mentor. He was supposed to be my mentor for 2 years, but that turned into a 15-year mentorship. It's quite happy. I would like to believe. Professor Menon, she's very senior professor of psychology from the University of Zambia. She's phenomenal to work with. She's a health psychologist. And she she also received an award for being the leading research in female researcher in psychology from Denmark 3 months ago. My colleagues from the University Teaching Hospital and from Kangaroo General Hospital, GOT One, who's actually been here on this follow-up study as well, not that much in the second review, but from there we've been friends with already throughout these years. In my team, to me, this is a wonderful place we've been pretty much trained up with my insanity for the last 6 to 15 years. And just thank you to all the partners who have trusted us with our work, given us funding, and hopefully it will continue. Thank you very much, guys.
And so I will have a question from the.
Sorry, sorry. Yeah.
So out of curiosity, what's your incentive package look like for the mothers? Sorry, and what is the difficulty in kind of figuring out incentive packages in a low resource thing?
So we don't refer to it as an incentive. These are very issues that are really Zambia, IRB, and the IRB. We don't use the word incentive because we measure that it's less studies. It's you compensate them by the time you measure the transportation costs, and then and the minimal amount that Infectious requires is, depending on their involvement, it's $3 or $4, or $5 per visit. So every time the mother can say, $5. The good thing is that so basically it's like then and the good thing is that the 6 to 8 weeks still falls within the 2 months, 6 months also falls within the follow-up, especially for preterm babies. So 12 months is we need to make sure they can do that. So what we do with certain forward studies is we call them on a monthly basis to check up on them, and to remind them that this is coming up, and also for us to make sure that the family is the job and say, I'm moving out, we can do a case and essentially it's a yes, we will second one. So from perspective of cohort studies, you have to be careful, not because there's a lot of attention and effort into the context. So not only get their athletes, and it's not that you can see the athletes like we would say in the US or something like that. Exactly. We also do like we have to try out then new landmarks, etc. So because then we work with community of workers, volunteers, you know the community inside out. So then you know what this and what this. And we get primary phone numbers, phone numbers, and some people they get that as well. And then in this case, we'll hopefully get the partners phone numbers as well. So we try to GPS them as much as we can.
Yes, I have lots of questions, but I will try to narrow it to down. So to one, what is your what do you imagine would be the next step after you do the RCP? What would be the intervention that you are imagining for especially like related to the kangaroo here? So how do you? I imagine that it would be intervention that would be motivating them or finding the tools of how to pick that up.
That's a very good question. And obviously, Bruno asked us this question as well. And then we thought about this in So we have national guidance techniques. We have that, that's in place. What if once we do the intervention and if we do see actually an impact, we actually on depression. What we're worried about, and we're trying to look for funding to add a fifth age to cost effectiveness. So pretty much what we're going to say is that if the baby is preterm, you should go to the emergency room before you go home. Right? In the US, that might not be a problem if you have health insurance, because you're not paying for it. Your health insurance will cover that. In Zambia, we do have health insurance, but we have national health insurance, but it's quite poor. So facilities are still being careful with the additional expenses. So the pushback is going to be this: like, can the hospital now say, instead of going home, I need to keep this mother here for 7 days? This is additional cost. But the reason why we want to do add a fifth day and hopefully a witness rate, someone to give us money, is theoretically, if we front load the costs, we keep the mother here for 7 days, then we may have less cost, government costs in the future, even up to 12 months. So less rehospitalizations. The less or lower rates of postpartum depression, which means the mother could go back to employment again. It's going to be a hard sell because a lot of the women's social economic status, unfortunately, are not in formal employment. However, it doesn't also mean that even though it's in informal employment, the person, your informal employer, may not say I'll sick leave for 6 months, even though you're not going to work, even though it's going to be minimum, whatever it is. So that's what we're trying to define the fifth objective, and then look for funding to say, yes, if this works, it's phenomenal. But I know you're going to come back and say, I'm going to spend more money. I think it's $150 a day. That was the NICU cost. Sorry, the NICU is $150 per day. I need to look into the cost of that 1 day with PMC. So even if it's $50, 7 days, that's $350 for 4,500 babies. Okay, not 4,000, some of them are 10 babies. But even if it's for 2,000 babies, now we're saying yes, you were doing 1,200, but now you're going to do double that. So that's a very good question. So that we need to prepare for this. We need to collect the data and have numbers ready. Because revising the policy is not going to be hard.
Right.
But revising the policy with enough evidence to say it's a front of the cost now, but we have a long-term impact. So that's going to hopefully help us.
And are you also, this might be beyond your scope, or you are focused more on that hospital care, but are you thinking about the home-based intervention, maybe with the community healthcare workers that will?
So KMC has been, we started decentralizing things, so there's even in Lusaka, Kangaroo, and some of the districts outside of Lusaka have it as well. We haven't, our communities volunteers do talk about KMC post-discharge as well, but there are a lot of people that talk about rigorous community KMC actually does reduce mortality, it does reduce profound infection. So yeah. So what we have is going to be, I think the dissemination of this the different aspects and different policy that we change.
Yeah, I think first, thank you so much. I mean, one can see how prepared we were. I mean, it took us to town. I mean, really well thought out in terms of your presentation. I really learned it. I'm African, but I learned it about just listening to you. So thank you for doing that. And I think the question I have for you is on comorbidities. You know, I mean, you had said that about 11% of Zambian women are HIV positive. And I can imagine that that has its implication for depression generally, mental health. So how did you, I'm just talking about how to account for comorbidities like HIV. I mean, I used to see that in the constitutional analysis, and I'm not sure they're thinking about that for the trial as well.
So account for it in terms of to look if there's a correlation. So for the RCT, yes. For the observational one, it was a very simple one-page data form. Pretty much the variables that you guys cite all fit in one page, and then the EPDS screening tool was the second page. We just wanted to have an idea of like the lay of the land, what's actually out there. For the RCT, we're going to have more detailed, properly developed data collection tools where we will look at in more detail social economic. Yes, it's not going to be just are you employed or unemployed. If you are employed, how much do you get paid actually per month? So questions like that. The partner's employment status as well, HIV status, linkage to care. Are you actually linked to care or not? Because you could have been dropped out of care. So there are many other variables that we will look at, yes, including number of children, possibly sexual debut as well. One thing we may think about, but this may be already too much, is looking at IPV or the danger or GBV. So intimate partner violence could be screened using there's a DA tool that Dr. Jackie, I think she's from Johns Hopkins. Yeah, it's a simple 5 question. Huh? Yes. Yeah. So very simple tool that you can do. So there are a lot of factors that you can look at and look into it as well. Yeah. So that's all for the RCT phase.
Yeah, and I think that would have implication for intervention.
Yes.
So because it could have been, based on what I was saying, there could be a subset of women for whom the KMC is really going to be a major game changer for preventing depression. It might not apply to everybody, you know, but it might apply to some HIV positive women who have suffered violence and so on and so forth.
Yeah.
So, and related to the question of community, How representative is the prevalence of postpartum depression from the person?
I feel like you're representing the donor. We had this question from another study that was starting. They asked, it's being done again in Lusaka. They said, is this representative for the whole country? I said, no, of course not. It's not representative for the whole country. The good thing, the benefit that UTH has multiple benefits. One, the high patient volume. So you can actually do studies in shorter period of time. But also UTH admits, which is going to be a challenge for us with the enrollment. It admits women or patients from throughout the country. It is the tertiary level hospital. So if the districts and the provinces cannot manage it, and for our cohort, we have the biggest NICU in the country. So if they can't manage the patient, everyone comes in. So we actually have patients who are outside of Lusaka as well, which is something that we need to now think about. Do we leave it open? But then what are the chances of them not coming back? Or what are the chances of them coming back? Like how small is the chance of them coming back for the follow-up visit? Or do we then restrict it to only those that live within Lusaka, because this is a proof of concept in a way. Yeah. So that's definitely going to be a challenge. Yeah.
Thank you.
Thank you. Any other questions?
So one of the things that always fascinates me is the stigma around a lot of the reproductive things. So not just the things of like abortion or something, but really something like infertility or having a preterm baby, right? And it's not only outside stigma, community stigma, but really internalized stigma. And how prevalent it is and how it impacts the health outcomes and of the baby, of the mother. It's really fascinating.
It is internal stigma, but
Like
in a
how
way,
deep it's going and into how many areas.
but in a way, it's dictated by the society, right? In a sense.
Right, yeah, but
generations,
of the culture and beliefs, yeah.
But I mean, so what I talked about, like only 4 minutes there. I mean, I talked about only this study, but the other, we're starting 7 studies next year, January, scratching in non-existing here. And it's going to range from preeclampsia to cervical cancer to chlamydia, gonorrhea, PPD, neopanda, which is looking at equipment for registration of vital signs, mathematical modeling, cervical cancer work. So we have quite a lot of studies starting next year. Just to put it out there as well, but for you guys if you're interested. But one of them, the cervical cancer one, it's a 48-month cohort. And one of the reasons where when women don't come back to the treatment if they're positive for precancerous lesion is because they can't have sexual intercourse for 4 to 6 weeks. So then the question is, I'll get to my husband about this. Right. So they'll skip the treatments, they'll skip the leak, which is usually removing this layer from the cervix. And they'll say, I'd rather put up with my husband than deal with my or
Right, or like pay attention. Yeah.
And also then telling the community about this, so it does come out. We've done a lot of we've done one stigma work, but it was primarily among the MSM population. There was intersectional stigma, then seeking healthcare services, and then what outlets in a way do they have. Irrespective of the unfortunately irrespective of the issue. I have topic. Yeah.
We do not have any questions on Zoom, so yeah. Any other questions, everyone? Well, we're right on time. Thank you very much again. Can we please give him another applause?
Thank you very much. Thanks.
Thanks so much, guys.
Thank you.